All right, I think we have most everybody. We definitely have a quorum, so I'll go ahead and get started. Hi, everybody. Happy Thursday. I think I've met everybody, but just to give you guys a little summary of why I'm speaking to you about this, my name's Emily Hartwell. I'm a clinical psychologist. I graduated from UCLA with my PhD in 2018 and then moved here to do a postdoc with Hank. And I'm now on the faculty and doing a grant using the Million Veteran Program data to look at genetic architecture of comorbid alcohol use, opioid use, and depression. So, but before I got into genetics, my first love was actually clinical practice and how to integrate all of the good research we do into the clinical setting. So all through grad school and during internship and postdoc, I worked in various clinics and various settings, treating people with substance use disorders and a variety of comorbid conditions. So my goal for today is just to give you guys a brief crash course in what some of the really good evidence-based treatments are and what they look like in clinical setting. I'll tell you a little bit about a couple of people I've treated over the years, but please stop me with any questions and comments. I know some of you have probably taken abnormal psych and heard some of this before, and I think this will probably be new information to some of you. So bear with me if it's something you already know, but hopefully we can have a good discussion. Yeah.
Are you recording?
Yes, yes. So we'll be recorded. It'll be up with all the other lectures. So briefly, what I'm going to talk about, I'm going to focus on cognitive behavioral therapy, motivational approaches, and contingency management. And if I have time, I'll give you a brief intro to 12-step programs, smart recovery, and behavioral couples therapy. So obviously, there's many, many more modalities out there and different types of treatment and new things that are coming out these days. But this is kind of, again, a crash course overview of some of my favorite modalities. But before I jump into telling you about specific ones, one of the things I always have to think about when I have a new patient coming into the room, first of all, is what is their goal? People can come in wanting to be working towards abstinence, and people can also be wanting harm reduction approaches. And if you guys have been reading the news at all in Philadelphia in the past few years, you've probably heard about things like needle exchange programs. That's a hot topic political issue. Methadone maintenance has been caught in political crosshairs as well over the years. Some people also want to come in and be moderate drinkers. So these are their goal, as well as my goal as their clinician, is an important consideration of what's going to be best for the patient and what are they really going to be able to achieve. Something else I always have to be thinking about too is what is the appropriate level of care? Is this person able to be managed on an outpatient basis? Do they need to have an inpatient stay? Do I need to get a physician or a psychiatrist involved in medical management? Based on their goals and how much they're using these days. As you guys have probably heard already, alcohol use can be really dangerous in terms of becoming abstinent. So when someone comes in telling me they're having a handle a day and they're going to go cold turkey and stop drinking, I'm going to say, no, not until we get a doctor involved in your care and management and monitoring you, because this can actually be lethal for you to do on your own. And of course, you want to be thinking about comorbid medical issues that are also going to need patient involvement. This is from the paper I asked you guys to review, the Ray et al. So again, we're going to be talking about some of these top modalities today, but I just like this figure to show that there's a wide variety of literature, and at this point, this figure is now several years old, and it might look a little different if we did a literature review today, but there's a wide range of options out there for folks to really help them get where they're wanting to go.
Can I ask something?
Yes,
out
of course.
All the treatments from the previous slide,
Yeah.
like which one is the most used?
That is a hard question to answer. So first of all, treatment is underutilized, as you've probably seen in all the box articles we've given you guys to read. That's a hard question to answer because there isn't great data out there in terms of those people who do seek treatment, what they actually get. And AA is notoriously hard to study. So like I couldn't give you a number.
But is AA the only one that might be like mandated by law?
No. So actually, when I was doing my internship at the West Los Angeles VA, we had people court mandated to treatment all the time. So they would come into our, I think it was a 16-week intensive outpatient program, and I'd have to sign letters and sign off on their attendance sheets and stuff. In terms of what's most offered at, say, hospitals and VAs, I think there's been a real push to what are the evidence-based care model. So that's a lot of CBTs being offered these days, I'd say. A lot of motivational interviewing, motivational styles, but I'd say there's a growing interest in research in some of the third wave treatment. So it's often a hodgepodge when you're talking about an inpatient program or an outpatient program in terms of there's going to be a variety of things offered.
So if you look at national data, population data, like national surveys, and you ask people whether they've gotten care, those that do, which are a small proportion, like 10, 15%, about 2/3 of them endorse AA. So that's probably the single most commonly used resource because it's free and it's everywhere. I mean, there are meetings all over the place.
I'll quote you some numbers in a moment.
Why did you say that AA is hard to study?
Because it's anonymous. There isn't a leader. There's no informed consent. There certainly is research about it, but it's been notoriously hard to get a good research design around AA because of some of its core tenets. So we've mentioned inpatient and outpatient a little bit. I just wanted to briefly talk about it. There is inpatient detox and treatment available. However, it's also notoriously expensive, often doesn't take insurance. These are some numbers from when I lived in Los Angeles. As you can see, they are quite high and they're actually several years old. So I'm guessing these numbers have actually increased. I couldn't even find any local numbers. I looked last week. You have to call and get some digging, do some digging, but just to give you an idea of what we're talking about here.
I don't want to know.
Doesn't it? The pictures are beautiful. Inpatient care, again, can be necessary depending on the severity of the disorder and if you really need close medical monitoring for a few days. It can be a good starting point to get people kind of in the door, away from those people, places, and things, and on the path to recovery, and then transition them to an intensive outpatient program. Okay, so CBT. This is really my bread and butter as a clinician. I love CBT. I think it's a really good starting point. If anyone's thinking about going into clinical work, I think it's a really good thing to learn right off the bat. And it was actually really the godfather of CBT. It was right here, Aaron Beck. So if you ever see his name on things, you can be pretty guaranteed that it's a good work. So the CBT model. So the idea behind CBT is that we all have situations in life that spur responses. Those can be thoughts, behaviors, emotions, and physical reactions. And all of these things are happening all at once. They interact with each other. They can increase each other and they can decrease each other. And the idea is that if you intervene at any of one of these points, you're going to break the chain. You're going to start breaking the cycle. And so the other things can start coming back down and normalizing. So would it be helpful to talk through a quick example? Okay, so I thought about this. What would be relevant to you guys? Let's say you're taking chemistry. You're really excited. It's a prereq. You got to take it for grad school or med school. You're almost done. You get to the final exam. You fail the final. You just checked, your courses. You see that you failed the final. What is the first thought that's going to pop in your head?
I should have studied more.
I should have studied more.
Like, I suck.
Yeah, absolutely. What else?
I probably self-doubt that I won't get to med school.
Absolutely. Me too. I'm a disasterizer as well. Okay, so those are the thoughts that are running through your head. Oh, I didn't study enough. I suck. I'm never going to get into medical school now. What emotion is going to come up as those thoughts are running through your head?
Anxiety.
A lot of anxiety.
Shame.
Shame. Sad. Absolutely. What's going to be happening in your body as those negative feelings and those rough thoughts are happening? What are you going to be feeling? Stress. Those stress hormones, that cortisol, that's going to be raging through those brains, right? What else?
Sweaty.
Sweaty. I get a knot in my stomach when I'm feeling anxious. I don't know about y'all.
Tight chest.
Tight chest. Maybe your heart's going a little fast. So then what are you going to do? What behaviors might you do in response to all of these things that are happening in your brain and body?
Cry.
Cry, absolutely.
Ice cream.
Yeah.
Did you say ice cream or scream?
Oh.
Some self-soothing, yes.
Yeah.
You're like, eat a lot.
Eat a lot.
Rethinking the situation over and over.
Yeah, absolutely. Going on that loop.
Probably will want to blame my professor.
Yeah, send out a hot email. How dare you make this final so hard? And
Caps.
in all caps, no punctuation. Somebody else, again, no one in this room, of course, might go have a drink to calm down, might go smoke a joint, might call a friend, right? There's a lot of behaviors that might go on here, both positive and negative. And we've all done all of, both, right? So the idea would be if that person typically goes and gets a drink, smokes a joint, etc., and that becomes a problematic behavior, right? That's a learned association. So now, oh, when I feel stressed and angry and upset, oh, if I go smoke a little, I feel better. Over time, that can become problematic, as you might imagine. If that's the only way you are coping with those negative emotions, over time, that can become a really strong association that's hard to break. So with CBT for addiction, we start saying, okay, so those negative thoughts are running through your brain, even when the situation doesn't necessarily warrant it. And you're still smoking, drinking, etc., to cope. So how can we break those cycles over the long run to help you start learning some other ways to cope, to deal with those negative emotions and counter some of those negative thoughts and calm your body down? Make sense? So in practice, what does CBT look like? It requires a licensed clinician. It's a very structured intervention, meaning you come in, the therapist comes in with an agenda that you are going to go through each session. So it's not a loosey-goosey psychoanalysis, let me talk about my childhood for the next 45 minutes kind of intervention. Typically between 12 and 16 sessions, but it is tailored to the individual patient. If someone says, oh, this anxiety is really something that drives my drug use, that's going to look a little different than someone who's depressed and that's driving their drug use. But it can be done both individually and in groups. It can be done inpatient, outpatient programs, and there's actually some nice evidence for virtual interventions being really efficacious. The CBT for CBT was developed up at Yale University, and as you can see, is very cost effective. It's about $100 for 9 sessions, which compared to paying $150 out of pocket for an individual session for 12 weeks, that's a really nice way to get people at least introduced. So again, learning and conditioning play an important role in the development and maintenance of addiction is kind of the underlying idea here. So CBT wants to help patients recognize their patterns, avoid cues and triggers, both of which are internal, some of which we talked about, if shame and anxiety, as well as, oh, if all my friends are drinking at a party, I'm definitely gonna be drinking at that party. So that would be an external cue. Coping with problematic thoughts and behaviors, as well as enhancing self-efficacy. So what it looks like is 1 to 3 sessions of an initial phase. That's where the clinician and the patient are getting to know each other, setting the stage for change, talking about what needs to happen in order for them to change their substance use. Also providing some psychoeducation about what CBT looks like, as well as building motivation. And then that middle phase is around 10 sessions where you're really focusing in on those skills. So are we focusing on coping with craving, changing those thoughts, dealing with those behaviors, getting away from problematic friends, etc. And then lastly, pretty much all different treatment modalities end with a termination phase, which is typically 1 to 3 sessions. And that's where you're getting ready to end treatment with the person. So you're talking about how are you going to maintain the changes you've done over therapy? How are you going to know when it's time to come back? There's really been a move in psychotherapy, I'd say in the past decade or so, to have episodes of care, meaning if someone comes into my office, I actually don't want to be seeing them forever. I actually want it to be kind of a discrete treatment period, send them back into the world, but I also want them to know when it's time to pick up the phone and call me again. So what are the red flags? What's going to get you into trouble? What's going to make you going to want to pick up that drink again? So some of the components of CBT for addiction in that early phase, that first few sessions, one of the things the clinician is going to do is a functional analysis where you're identifying the thoughts, feelings, and circumstances that occur both before and after use, and identify those positive and negative consequences that go along with it. During the skills training phase, so that middle phase of treatment, again, you're learning coping skills for dealing with stressors. Again, interpersonal and intrapersonal are taught. You're providing psychoeducation. So that can be, what does alcohol use do to the body over the long term? What are healthy limits of drinking? Coping with craving, doing cognitive restructuring. So that's really dealing with those negative thoughts. How do you cope with them? How do you challenge them? How do you arrive at something that's more balanced? You might be doing refusal skills and assertiveness. So this is someone who's really a social user, is going to need to know how to interact with people and not use. For a while, maybe they can't go to a party with their friends because they know they're going to use. But how can we get you to a point where you can, be in a situation and still stay within your values and what you're trying to do? You're going to be doing problem solving. And again, that final phase is that relapse prevention. So this is from the project Match. I'm happy to give you guys this paper, but this was their layout of sessions, just to give you an idea of what this might look like in terms of a normal episode of care. The empirical evidence for CBT is very good across a variety of disorders. A meta-analysis done by my former lab showed that CBT had moderate to large effect sizes compared to no treatment. And CBT is also very effective when combined with other medications, like naltrexone. You've heard about some of these medications, and we will be over the course of the summer. That's really effective. And a different meta-analysis showed that meds with CBT were better than meds with just treatment as usual. So a good combination is definitely a good thing. So the pros, compared to inpatient treatment, brief, relatively affordable. Again, kind of depends on where you're getting the care. It really has that focus on skills building and helping the patient develop themselves and have some things to rely on outside of session. Great research support, and you are seeing a trained practitioner who, ideally knows what they're doing a little and has some skills and resources to help the patient. Cons, it can be expensive, especially if you're paying out of pocket for, private therapy. There's a reliance on cognition, which cognition can be impaired with long-term substance use. I often find that I don't jump into CBT with someone who's kind of brand new to sobriety and just getting their feet under them. I have a few sessions before get their feet under them, let that brain recover a little bit, and then start trying to do some of the skills building. A limited focus on motivation. I'm going to talk about motivational interventions next. But that can be integrated very easily into CBT, but it's not a focus. There's no social support necessarily built into this, unlike AA, where you're sitting in a room full of people who are also going through the same things. Often CBT is delivered individually, so you're not going to get that aspect of it. And there is homework with CBT. You're sending those patients home with some worksheets and some tasks to do, which personally I like. It helps people kind of build in that practice. When they do it is the kicker. So if someone's low motivated, they're court ordered, they're still in that early path of sobriety, getting people to adhere and do it can be a real challenge. And it also requires some level of cognitive and reading skills. So that's my spiel on CBT. Any questions or comments? Yeah.
I don't know about CBT specifically, but has there been studies of DBT for addiction?
There have been. That is on my final slide. DBT I love. I think it's a phenomenal modality. So this is dialectical behavioral therapy. It was developed for folks actually with borderline personality disorder, but it has phenomenal research support for, of course, personality disorders. I actually led a DBT group in the outpatient program across the street at the VA for a couple of years. I think it's more integrated into care as opposed to a standalone treatment by and large. I don't know what the research support is for it as a standalone treatment, but in terms of building the skills for mindfulness and distress tolerance, I think it's very effective. Again, not necessarily for those folks who are brand new to sobriety, but I found the folks who'd been 6 months in and were kind of ready for a deeper level of skills, it was great for, and the veterans loved it. We were always full. Any other questions? Yeah.
For people who are sort of brand new to sobriety, like you mentioned that their cognition might be a little bit impaired. Are there other techniques that you use to help get them on their feet?
Yeah, for those folks, I really like to start with the motivational approaches, which I'm going to talk about next. Just kind of learning, what's motivating you to get here, what are the things that are going to help you stay sober and stay committed, and a lot of rapport building with those folks. Getting to know them, really understanding their story, I think is very important in terms of getting them in the door isn't the problem, keeping them in is the biggest issue. Fun fact, the modal number of treatment of psychotherapy sessions folks have is 1. So I really, I go into those initial assessments thinking I might not see this person again. So what can I do to give them a gift of self-efficacy or, help build that motivation in case they don't come back. And that's a real crapshoot. You never know with a patient, unfortunately. So I think, yeah, focusing on motivation and rapport and just getting them stable. So if that person is still in an unstable living environment, is their partner using? Is this how they make their money? What are those things around them that are going to lead them to continue using? What are those things that need to change? Because otherwise you're not going to be able to do the work of CBT or DBT or any other modality you pick if you can't get them in a safe environment. So motivational approaches. This is my other favorite thing in the psychotherapy world. I worked on a variety of studies at UCLA that were just one session MI interventions. This is a really great approach that can be combined with really any other modality. I don't care if you're going to med school or grad school, if you're going to see a patient, learn MI because you can use it for everything. So motivational approaches are really designed to produce rapid internal motivation change by examining ambivalence. The main components are you start with an assessment, and this can be as brief as in giving an audit questionnaire, or just querying someone's substance use. It can be full-blown diagnostic assessments, so that can be really moderated to the individual patient and how much time you have. You're giving very brief feedback and assessment, and then you're talking about building and maintaining that motivation to change. And this has been applied to a wide variety of health behaviors. So substance use is certainly one, diet and weight management, and other health disorders. We had a nurse working with us who said, oh yeah, I know this. We did this in the diabetes clinic all the time. I know this already. We're good. So really anyone who's thinking about seeing a patient in the future, this is really good to be able to fall back on. In terms of the evidence for substance use, this is a meta-analysis that was published in Addiction. And so this is at 3, 6, and 12 months. This is a meta-analysis of over 14,000 patients. And the patients that received the brief intervention had fewer binge drinking episodes than those who didn't. And there was a similar pattern for drinks per month and drinks per drinking month. So again, this was a one session brief intervention and has really nice long-term gains. So this is one of the kind of setting the stage ideas about motivational interviewing. So this is how they kind of conceptualize change. So you can see the red star in the upper left-hand corner. That is the pre-contemplation stage. So all of us are in the pre-contemplation stage in this room about something in our lives. And that's when there's no intention of changing that behavior. From there, you move into the contemplation stage. That's when you're aware there's a problem, but you're not doing nothing about it. Once you've decided to do something, so this patient comes in saying, okay, my wife's really been nagging me. I know I need to quit drinking or at least cut back. What do I need to do? Just by taking the act of saying that out loud and coming to my office, they have now entered the preparation stage. So that is when you're intent on taking action. I think this is the stage that's easiest to rush through, and a stage I often encourage people to sit in and take their time with and really set the stage for success in the later phases. For example, I was working on a study of heavy drinking smokers. Everyone was getting varenicline to help them with smoking aids, cessation. And so many people would say like, okay, I'm good. Let's do it tomorrow. I'll start taking the meds. I'm stopping smoking. And I'd say, okay, that's great. I'm so excited that you are motivated and you're feeling confident about this. But let's take a step back. How much are you smoking these days? How many cigarettes are around your house? Are people in your house smoking? Where are all your lighters and ashtrays? Let's take a week. Let's do some cleaning. Let's limit your access. Let's talk about how you can keep motivated once that quit date hits. Let's set a quit date of a week or two out. And then the person goes, oh yeah, I have a really stressful event at work next week. There's no way I'm going to quit smoking. That's, you want to be able to help people think through this preparation phase really carefully. Again, it's the easiest to rush through, and it's the one I really try to slow people down on. Once the person is actively changing, the behavior is decreasing, they've set that quit date, they're in the action phase. So that's when you're doing the things, you're coming to your appointments, you're taking your meds, etc. And you're really actively working on changing that behavior that you've identified. I know that people are moving into the maintenance phase when they stop having to think so hard about it, when those old habits aren't so challenging to replace, and when the new habits don't have to be thought about so much. So for example, I was working with a veteran, long-term history of alcohol use and depression. And when he'd come to my sessions with me, he lived in New Jersey, he used to take a certain route home that went by his favorite liquor store. And so in the course of our working together, he goes, I need to stop driving by this place. I stop after our sessions and then I feel guilty. I'm going to take a different route home. And after a while, he said, it's been so long, I'm doing so good. I took my old route home. Didn't even faze me, didn't bother me. Now that was several months. I don't want you to give you the wrong impression. That was a chunk of time. But when he started saying things like that to me, he wasn't so much in the action phase, he was moving on to that maintenance phase. As you can see, there's a big purple arrow, meaning people can exit this stage of change wheel here. And of course, we know that addiction is a relapsing remitting disorder. So people often go through several lapses. I don't have a good number, but a lot of times there's a relapse that happens. But ideally, you can see this upward spiral, the patient's learning from each relapse and doing better, easier, moving through these phases a little easier the next go around. Because oftentimes, again, a lot of the people I see, this is not their first go around in treatment. And they say, well, this worked really well for me, or this med worked. Going to AA, getting some new friends, blah, blah, blah. Whatever they learned, what worked for them and what didn't work for them is really important. And one of the things I love about MI is that one of the underlying assumptions is that the patient is the expert on them and you're there to help facilitate it, as opposed to a top-down approach of saying, okay, I'm the doctor in the room, here's what you're going to do, this will make you successful. No, that's not the approach we're taking with MI. The patient is the expert on them and we're going to help them be successful. So the format, again, with the trained clinician, there's been evidence for both individual and group settings, and really can be administered in whatever clinical setting you're at. A very brief intervention, again, the vast majority of ones I have had are 1 to 2 sessions, and again, can be very easily combined with whatever other treatment you're using. And can be used during a different treatment. I was working with someone doing cognitive processing therapy, came in halfway through our 12-session format and said, oh, doc, I'm done. I don't like this. This is too hard. I'm not getting anything out of this. This is not helping my trauma. And so we just took a step back. We did not do session 6 of CPT that day. We had an MI session where we took a step back and said, okay, what's motivating you? What's working? What's not? So again, very helpful and easy to implement. So I already briefly mentioned this. There's an assessment. So whatever behavior you're wanting to intervene on, you need to know what they're doing, obviously. Someone who's drinking really heavily, that's going to be a different assessment and intervention than someone who's a really light drinker. You're providing extremely brief feedback and advice. And by that, I mean 2 sentences. So I might say to someone, what you've told me, based on what you've told me, you're drinking really heavily. You're drinking outside of the NIH safe drinking guidelines. And you're telling me about some negative impacts that's having on your life. And the best advice I can give you is to cut back or stop. But what you do with the information we talk about today is up to you. That's the meat and potatoes of this intervention, right? That was pretty easy. You're often providing a smidgen of psychoeducation. So again, what are the impacts on the body? What are the long-term impacts on the brain? Something brief, whatever is most pertinent to the condition you're talking about. You're then spending a little time building motivation, so talking about the pros and cons of using, and then talking about the importance and confidence. So these are rulers. I just have them printed out in my desk on a scale of 0 to 10. How important is it for you to change this behavior? And 0 to 10, how confident are you in building this behavior? So someone might say, oh yeah, my smoking's really getting to me. My lungs are hurting. When I was working on that heavy drinking smoker study, I had so many people from the food industry coming into that study. So I had several people who were chefs saying, I can't smell my food anymore. This is now impacting my work as well as clearly my body. So they might say, okay, the importance for me to cut back on smoking is a 9 because I can't smell my food. I don't know what I'm serving people. This could really impact me. Confidence, in all the sessions I've done, I can never predict how confident someone's going to be. Some people are very, I think, optimistic and say, oh, I'm at a 10. I say, okay, great. Tell me why. Why are you at a 10 and not a 3? And that's a really helpful way to get people talking themselves into change. Why is it an importance of 9? Why is it not a 5? And you get them to list the reasons why they want to change. Now, when someone tells me their confidence is really low, like a 2 or a 3, I say, well, it's still not a 0. You still have a little bit of confidence. Tell me about that. And when someone says, well, my confidence is at a 0, and again, you want to explore that with them and get them to talk themselves into what that change looks like. And when they say a 0 for confidence, I say, I hear you. This is going to be hard. Change is hard for all of us. What are the things we can do to bump you up to a 2 or a 3 that we can talk about right now? Which is the last part, setting a goal with someone. So you summarize the whole session and you say, I hear you. You're telling me you want to make at least a small change in this area. What does that look like? This can vary widely. You can set a substance specific goal. So someone might say, I'm drinking every day. I'm drinking 12-pack every day. I need to cut back a little bit. So this might be the time where I say, that is great. Again, we need to get that physician involved to do an assessment and talk about medical management. So the goal might be calling their doctor and getting an appointment. Someone else they might say, I'm smoking a pack a day. I'm going to cut back to half a pack a day. Great. You want to talk about how they're going to strategize that and how they're going to be successful. The underlying principles behind this entire intervention are expressing empathy, developing a discrepancy. So again, you're using this much, but you're telling me about these problems. How are we going to build you towards being in line with what you want to do? You don't want to argue with the patient. Easy to do, easier said than done to avoid trying to talk them into something. But that's one of the principles, is really avoiding that. And you want to roll with resistance. So I have definitely done this before. You kind of trip up into something and someone says, oh, I can't do that, or I don't want to change this. That's okay. MI is very much about letting the patient, again, be the expert on themselves and what they are capable of doing. And throughout it all, you're supporting the patient's self-efficacy. So the pros, again, there's strong evidence for substance use reduction. It's actually been shown to be effective with adolescents. It's very brief, easily combined with other treatments. Therefore, it's very cost effective. Again, I really love that it meets patients where they're at and what they're ready to do, as opposed to an AA type approach, which is abstinence only or get out the door. And it's also focused on building rapport. May not be more effective than other treatments in terms of cons. And it's not appropriate for those with more severe SUDs, if you remember from the the graph I showed you earlier. And it does require someone with a little bit of training, but doesn't necessarily need to be a full-time clinician who's just doing MI all day. Questions about MI?
I have a question for in general. Like,
Sure.
when you give like these therapies to the patients, like, do you explain like this is CBT and it's supposed to like change your mindset, whatever? Like,
Yes, informed consent is incredibly important
Yeah.
to me and in my line of work. I'd never start a new modality without talking to someone first. Now, a brief MI intervention, I might just be using that kind of off the cuff in a session, but in terms of starting like a DBT, a CBT, yes, you are talking to the patient, you are getting their consent, and you are making sure they understand what is going to be expected of them. Like, to go back to that patient I was talking about with the cognitive processing therapy. Before we started that, we'd been working on his sobriety for a long time. He really came to the realization that his trauma was what was driving a lot of his substance using behaviors. So after we kind of got some sobriety under his belt, I said, okay, you're telling me your trauma is really still the trigger. Here are the options. So we talked about prolonged exposure therapy, cognitive processing therapy, developed that menu of options and said, what feels right to you? What am I trained to do? And what will that look like? So yes, you absolutely want patients to be on board before you just start throwing something at them and making sure it's in line with their goals and their ideas.
Do you feel like sometimes that affects their behavior and response to the treatment?
That's what I was
Negatively,
getting at.
like,
Like maybe
If they understand, and this may be like a very extreme scenario, but if they understand how the treatment works and what it's supposed to do, does it affect, do they try to get by just, doing the bare minimum, or like,
doing what they think they're supposed to do.
yeah.
There's certainly people that want to appear well or, get the A and pass the grade. And there's
Also probation.
Yeah, yeah. I feel like those folks don't typically necessarily stick around. They, you know, don't necessarily want that long-term relationship, whatever. But you still want them to know what they can expect from a certain treatment. And they might say, this particular patient, he was kind of like, I'm not feeling better. I don't like this. It's a lot of work. And I said, yeah, we talked about that. It is a lot of work. Cognitive processing therapy is a lot of homework and a lot of digging into someone's past experiences, and it can be really trying. It's often more distressing before it gets better. Some people tolerate that and some people don't, but you certainly don't want someone to go in blind without the right expectations around these types of things. And so those are the moments where I do sometimes pull back and say, okay, let's revisit the psychoeducation piece. Let's talk about what this is going to look like and what you can expect both of me, of yourself. And also sometimes you got to revisit. There's definitely times where I've started down a path with someone and said, oh, this doesn't seem to be working for either of us. Let's revisit. Let's talk about what is going to be useful for you. And maybe that's not working with me, or maybe that's working in a different, taking a break, etc. So it's very important to kind of be revisiting that for both of you and being okay as the clinician in the room to say like, okay, this isn't working. Let's try something else.
Is there a way that you advertise these type of treatments to people that necessarily don't like believe in therapy?
Like, how would I let them know about it?
It's like, what I'm thinking is that a lot of people just don't think that therapy is a thing,
Mhm.
especially like, people of color and a lot of men.
Mm.
So I'm wondering, like, is there a way to advertise these in a sense that is more like maybe like, you know, like medical intervention in their mind instead of like therapy, so that they do it?
Yes, I mean, working with veterans, I'd say there's still a lot of stigma and misperceptions. I think that is slowly changing. They're doing their best. I think the VA has really undertaken a PR effort to provide that kind of education. Like, you guys walk over there, you'll see there's just flyers and brochures everywhere that really describe like, here's what it works. Here's testimonials from people who've done it on our website that you can access. So I agree with you. That's definitely still a problem. And I think there are, organizations that are doing a good job at trying to educate the public. As an individual provider, that's hard to make systemic change, obviously, in a system. But I think there is an effort to say, to destigmatize as much as possible, to really get individual patient stories out there to make it more okay, as well as build that group environment in terms of, you're clearly not alone. There's 20 other people in this room who are dealing with the same issues. But in terms of medicalizing it, I think in substance specific, there's been a move to clarify that addiction is a brain disease. And therefore, like anything else, you wouldn't take care of that. Like any other medical disease, you wouldn't necessarily treat that on your own. It's okay to get a team, whatever that looks like for you. Anything you want to add, Hank?
No.
Okay. Did that answer your question? Kind of. But yeah, that is definitely still a big issue. And I think the public health education front can really help us out.
What's really interesting is you're pointing out the different mindset between the approach you're describing and the medical model.
Mhm.
Medical model is very paternalistic, parental.
True.
I'll use that term. And a lot of people like that. I mean, they want to be taken care of. They want to be told what to do. It hasn't appealed to everyone. And this is a different approach. This is more of a partnership approach. Let's do this together. You're capable of it. Puts responsibility on the patient, more responsibility on the patient. You look at adherence to medications that are prescribed by your doctor or your clinician. About half of the time there's adherence. Only about half the medication that's prescribed for people is actually used. Think about that. Across all disorders, half the time. So basically, that's like having one hand tied behind your back. Is the medication does not help if you don't take it. And so, so this kind of approach, I think, is probably more realistic in many ways. I think there's an illusion that traditional practitioners that the patient's going to do what you say. It's an illusion.
And I think I really wanted, as a newbie clinician, one of the things that really drew me to MI is just what Hank said, putting the onus back on the patient. That this is up to them. They want to do this change. They want to work the treatment. It is on you to actually do it. And that took a lot of pressure off me when I was a brand new grad student, feeling like the weight of the world was on my shoulders to help my, grand total of 3 patients. But I felt a lot of pressure there at first. And to me, putting that responsibility back on them really took the weight off. Any other comments? Okay, really briefly, contingency management. As you guys may or may not have heard already, stimulant use disorders have no FDA-approved medications for them and are notoriously difficult to treat. And contingency management is currently the best thing that we got. The evidence is really good for stimulant use disorders as well as some other substances and other health behaviors. And it definitely has a big push at the VA right now. So contingency management involves giving tangible rewards to reinforce positive behaviors. That can be abstinence. So you come, you give me a clean UDS, you get to draw a prize. Attending appointments, taking your meds. So for example, one of the pushes at the VA is, did you come? Did you take your Vivitrol for your opioid use disorder? Great, you get your drawing. It is a conditioning based approach. There is a voucher-based reinforcement. So for example, you get a voucher for every free drug-free sample you provide. You start with really low rewards and build bigger ones as you provide consecutive clean samples. And there's prize incentives. So for example, the example I'm going to talk about is drawing from a bowl for a chance to win prizes for every negative urine screen. So the principles here are built around regular testing to ensure the patient's use of the substances is readily detected or they're getting their medication. Tangible reinforcers when the abstinence is demonstrated and you agree upon that beforehand, again, informed consent. Designated incentives are withheld when the substance is detected, and you alternate and healthier behaviors are also established to compete with the reinforcement derived from substance using lifestyle, which is what we were talking about before. What are those coping skills? What are you going to do instead? How are you going to stay on the straight and narrow? So also often paired with other treatments, this is a really quick intervention. All things considered. So if someone's also in CBT or doing some other groups, that's a-okay to combine this. Research has shown this increases treatment retention, medication compliance, pro-social behavior. Obviously, this is a goal-oriented activity. Meta-analysis showed a moderate effect size, but as you might expect, those impacts diminished over time, right? If you're getting reinforced for a certain behavior and now you're not getting that reinforcement, is it going to keep up? Hard to say. But very good for opioid, cocaine, meth users. Okay for other substances like tobacco and polysubstance users. But again, there's more efficacious treatments for some disorders over others. So this is from Dom T. Philippus, who's really the CM godfather over at the VA. So what you start with is selecting a specific objective target behavior. You measure that target behavior objectively and frequently. You provide immediate tangible rewards when that behavior occurs, and you can escalate the size of the reward for consistent behavior. So you might say, okay, after 6 clean urines, you're coming in every other week. You're giving me a clean urine for 6 appointments. At that point, you're going to get a much greater reward. So then you're kind of helping people build towards something. You withhold those rewards when the behavior doesn't occur, so the person doesn't show up for their appointment, they come in with a dirty urine, etc. And then the prize size is reset. So this is the fishbowl protocol. So patients earn prizes for varying magnitudes based on draws. The fishbowl has 500 slips. There's half of them just say good job. Some say small, so you get $1. Some are large, and then there's one jumbo. So you start with 1 for the first negative sample and escalate to a cap of 8 as the person shows consistent abstinence. When abstinence can't be verified, no draws are earned, and it resets to 1 for the next sample. So, and you can see he's quoted an average cost for 12 weeks of $200. So this is kind of a little bit of money off the front end to invest in this. This can be obviously expensive depending on the size of the clinic. So that sounds easy. We reward veterans for healthy behavior. Yes and no. Yes, the concept is simple, but how you conduct it is really important. So again, being extremely clear with people, getting that informed consent, making sure they understand it, very specific and regularly measured outcomes, being consistent across the variety of behaviors. You don't want to be inconsistent or delay consequences and withholding that reward.
Forgiving.
We're
You
good.
don't want to delay.
Right. And you don't want to inadvertently reward the problem behavior, and you don't want to set the bar too high or too low. So again, kind of using that MI approach to saying what's going to be reasonable for you, what can we both agree upon that's going to be actually achievable for you. So pros: strong research support, effective across multiple populations, effective when combined with other treatments, very effective for stimulant use disorders. You don't need to be a licensed provider to conduct this. Pretty much anyone who's staff in your clinic can do these sessions. Cons: possible to return to original use once the reinforcers are removed. Expensive, somewhat labor intensive. The visits themselves are short, but setting up, getting the resources, getting the labs, etc., all of that obviously can be time intensive. Okay, questions, concerns about CM? I'm just going to briefly talk about 12-step programs since it's come up. So these are AA, NA, Al-Anon. So that's if you have a loved one struggling with addiction, as well as 12-step facilitation, which is basically just the AA module kind of repackaged for like group settings and other types of clinics. So this was co-founded by Bill W. and Dr. Bob quite a number of years ago. June 10th is considered to be the founding date of AA, which we just passed. And this organization has grown by leaps and bounds since the 1930s, an estimated 2 million members in 180 countries. Typically in person. Obviously during the pandemic, there were a lot of online groups. It's very informal. Each group sets their own structure. There is no set leader of the group. There's no trained clinician in the room. There's open meetings, which I would encourage you guys to check out. If you're remotely thinking about addiction or doing clinical work in the future, go sit in on a couple of open meetings. Don't go to the closed ones. But most importantly, there is no fee, and these are super duper accessible. I have a number on a later slide. Typically, the format of the sessions, they open with the AA preamble, serenity, prayer, introductions. There's a discussion. Whoever's the chair of the meeting at the time selects a topic. One to a few people speak. They talk about one of the steps, traditions, or read from the big book, which if you're interested in any of those, I have all of those in my office. So here are the steps if you've never seen them before. There is a lot of religious language. This was obviously designed in the 1930s. America was probably a little different back then compared to where we are now. There are groups that lean more into the religious setting, and there's groups that don't. What I will say, AA was a little bit ahead of its time in that you didn't have to be a particular sect of any religion. It wasn't just for Catholics. It wasn't just for Lutherans. It wasn't just for Jewish people. They were okay with you as long as you were a religion of some sort and believed in God. Again, this is very abstinence-based, which can also be problematic. Not everyone who's ready to start their journey is ready to be abstinent right off the bat. And they are really not down with medication treatment either. So that can be kind of problematic as well as people are starting their sobriety. So their strategies are working the steps, coming up with a 24-hour plan, meaning, okay, I'm not going to drink today. I'm not saying I'm never going to drink ever again, but for the next 24 hours, I am a sober person, coming up with a plan for how they're going to do that, one day at a time. AA was also ahead of its time in saying that you needed to change people, places, and things. We now know from imaging and neuroscience that that is very smart, right? Getting those cues lit up, like I was telling you about the veteran who had to take a different way home because seeing his old liquor store was too triggering. What if you change? Places. People who their whole friend group is using and smoking and drinking, and so they are using and smoking and drinking. What do they need to do? Find some new friends and find some new ways to fill their time. They also have a first things first, meaning don't put the cart ahead of the horse, and easy does it, meaning don't put too much pressure on yourself to do this perfectly from the get-go. You get different chips as you have more sobriety under your belt. Again, this is a really hard group to study, but in terms of what is known about the mechanisms of change, the common factors are building self-efficacy, building commitment to change, motivation, helping with behavior coping. Some of the specific AA practices have been found to be really important to some folks. And the social and spiritual change mechanisms are also really key, which you don't necessarily get, as I mentioned, in some of the other modalities. You're not getting that group setting of people going through the same things. So pros, it is very affordable. You get that sense of community. Oftentimes you're going to have a sponsor. So that's that person you can call in the middle of the night when you're feeling really triggered and craving really high. There's no wait list. If you go into the AA website, you will see there are going to be a number of meetings today that we could all go to. When I last looked, there were 288 meetings within a 10-mile radius of my apartment. So, and that was in 1 week, in a 1 week period. So again, as Hank said, this is super duper accessible, and it's really easy to find groups with different communities. There's some that are just for women. There's some that are just for certain ethnic groups, etc. So you can really find kind of your group of people. Cons, it isn't a group. Some people are not comfortable with that. They're going to sit in the back and never really participate. There is limited research in that we don't really know what the success rate is of an AA only approach. It is abstinence only. And if you are taking meds, they are not going to love that. They are very kind of cold turkey, get it done kind of approach. I had a veteran who was on buprenorphine, and they basically kicked him out of the group because that was not okay, even though he was doing beautifully on it and ended up having a relapse because he wanted to stay in the group and stop taking his meds. So obviously he did not go back to that group. It is peer-led, which is kind of a pro and a con. I think people feel really comfortable with that, but obviously this is not someone who's a trained clinician. And it is kind of a self-help based approach. There's that emphasis on spirituality, which again, some people love and gravitate towards, especially the older veterans I've worked with. They really like that and connect with that. I find the younger crowd, it's a little more hit or miss. There's really no way to monitor compliance. Again, anonymous is in the name, so you can't really take attendance every week and see who's coming. And I've already talked about that. Okay, for the sake of time, I'm going to skip through these two.
I have a question with AA.
Yeah.
At least with like in terms of like monitoring compliance, isn't there at least like within the group? Because I know you usually get like a sponsor also. So wouldn't like at least like within group you're monitored a little bit because you have like a sponsor?
If you have a sponsor, and if you are talking to them and meeting with them with some regularity, but there's a lot of ifs in that sentence. Ideally, yes, but there's no sort of built-in like we're checking in once a week or whatever. You know, there's a lot of variability. So for some people, yes, that definitely is a component. It's just not standardized in any way.
Like, but you don't need like any qualification whatsoever to lead an AA meeting. And is it just the same person that's like the AA leader?
They call it a chair, and it actually it rotates. Again, it depends on each group is a little different, and they're allowed to operate kind of however they want. But there's typically an identified chair for a number of months, and they pick out, you know, the reading and all that, and kind of make sure there's coffee and like that kind of stuff.
But
there's
chair
no
is
qualification.
recovering.
Yeah, they're a member of the group.
As a clinician, do you feel skeptical of what goes on?
Yes and no. I've had a lot of people who really like it and get something out of it and get a new community. So in that sense, I'm all for it. If that helps you fill some time and make some new friends and you learn something about yourself, great. Do I typically encourage people to only do that? No. I say go check it out, see if you like it, see if it'll help. If you go for a month and you get something out of it, great. You go for the next 8 years, great. If you don't like it, that's okay too. So yes, I am skeptical, but I'm still for it in that I'm for whatever works for the individual patient. I mentioned this briefly already, but pretty much any treatment minus AA is going to have a few sessions of relapse prevention there at the end. So you come up with a specific plan, you write down, you talk about it before you end your treatment episode with the patient. Really stress the importance of returning to treatment, whether it's with myself or with someone else, if and when those red flags come up and they're feeling stressed and needing some extra support. I often still have continued smaller contact with folks after they terminate, you know, maybe a couple of phone call check-ins. And you can also certainly modulate that for the individual patient. So maybe you say, okay, we're going to terminate our regular treatment here, but why don't we make an appointment in 3 months, do a quick check-in, see how you're going, see if you need to come back, or if you're good to go. So as already previously mentioned, I did not cover a lot of other types of therapy, including some of the third wave treatments like DBT, that also includes acceptance and commitment therapy and mindfulness-based relapse prevention, all three of which certainly have evidence for folks with substance use disorders. ACT and DBT, again, probably not a sole treatment for someone, certainly not early on in sobriety, but definitely offered in terms of intensive outpatient programs and available to folks. The matrix model is kind of a hodgepodge of how you put these things together and actually have an intensive outpatient program that draws upon these different techniques to help people maintain that early sobriety. There are therapeutic communities where you can go and live when you're kind of, again, in those early stages. I didn't talk about psychodynamic models. That I feel like would be more appropriate if we were talking about depression. There is brief psychodynamic treatment for depression that is very efficacious. Not so much in the substance use field. That's a real insight-driven psychotherapy. And again, when you're dealing with someone with substance use, you really want to be building those skills in self-efficacy as opposed to how do we have insights about your whole life and move from there. So that's something I would be recommending people do later on. And I also didn't talk at any length about disorder-specific therapies. That, as I mentioned, I was doing cognitive processing for someone who was dealing with an opioid use disorder. That was something we started 12 months into knowing each other. That was not something we remotely broached right off the bat. So if there's a lot of other disorder-specific types of treatments that I definitely encourage you guys to look into. I'm happy to talk more about individually. Obviously couldn't cover all of them today. Any other questions before we wrap up?
Where's that goal?
That's the evaluation.
Oh,
So don't forget to do your red caps. Again, this was a little bit of a crash course, but I definitely encourage you guys to continue checking some of these out and sit in on groups as you can and are able.
Yeah. Have you looked into like there's now psychedelic therapy for tobacco use?
Yes, and alcohol and a variety of things. We are kind of thinking about tiptoeing into that world. Yeah, I'm for what works. If there's good evidence, the paper that came out on psilocybin for AUD last summer was really good. We wrote a commentary on it. So it's definitely an area I'm excited about and interested in. I think we need a lot more legwork done before I'm going to recommend it to everyone right off the bat.